Well, hello everyone. I hope you're enjoying your lunch. And I'm told you can ignore the sign that says no food or drink in the auditorium for today only. So you can still run out and grab something if you're hungry. I'm Joe Palca. I'm a reporter at National Public Radio. I've been covering health and science and whatnot for the last 17 years at NPR. And this session is one of the big idea sessions, and it's called The Globe. And I was asked to give a few remarks to set up this question, and I thought, oh my goodness, what am I going to say? And I thought two things. If you're going to talk about the globe, I think you'll all agree it's important to think globally. But I thought that was sort of obvious, so I was going to encourage everybody to think locally as well, because I think that's an important thing to consider when you're trying to have a global impact. And let me tell you what I mean by that. So I would argue that eradicating polio is a sort of a globally significant and important goal. And yet, if you just march into a community with your polio vaccine and say, here it is, I'm ready to give it to you, and won't you be happy to have it, you can find yourself kind of surprised, as the health workers in Nigeria found in 2004 when the Muslim clerics were encouraging their flock not to get vaccinated. And in Indonesia, similarly, in 2005, there was resistance on the part of people who thought that the vaccine was going to be dangerous to them. So, so there's those examples. Another is I was reporting about a global tobacco eradication program from Cambodia. And if you march into Cambodia with a Western-style campaign to eradicate smoking, you're starting at the wrong place. Because in Cambodia, people weren't aware at that time that smoking was bad for you. This is only 7 or 8 years ago. And the way I can emphasize that is that the Buddhist monks in Cambodia, who are not supposed to take harmful or dangerous substances into their body, were smokers. And there was a campaign actually to encourage people to quit, but they started by trying to encourage the monks to quit. And it's a very odd sight to see, this meal being prepared in a wat and have the monk light up afterwards, with a cigarette. So and lest you think that this is a developing country issue exclusively, I would make the point that a few years ago I was covering the trial of a chemoprevention for cancer using tamoxifen versus placebo. And I interviewed a lot of women who were participants in the trial, and the women in this country, the United States, almost invariably said to me, oh, I'm in this trial because, it's important for my daughters, and it's important for my nieces, and it's important for all the women in my family, and I really think it's important that I participate, and it's very much more of an altruistic message. And I went to the UK, where they were doing a similar trial, and of course there's the National Health Service in the UK, and most of the people who are participating in this trial of tamoxifen versus placebo to prevent breast cancer were also part of the National Health Service. And I asked them why they were participating, and almost invariably their answer was, so I can get a doctor on the phone right away if I find a lump in my breast, because they didn't want to wait 2 months for a doctor's appointment. So I guess my point is that you can be fooled by thinking that your rules and cultures are the ones that apply to everybody. And so I hope we think about the local issues as we go forward with today's talks. We have a series of, from what I've heard, very interesting talks. And we're going to start with Matthew Dowd. He's the founder of Via Novo, and for the past 25 years has helped shape strategies and campaigns for CEOs, corporations, foundations, governments, candidates, and presidents. He currently serves as an analyst for ABC News and a consultant for the Gates Foundation, where he's involved in working out how to communicate issues of global health to the public. So, Matthew Dowd.
Thank you, Joe. Everybody here? It's actually an interesting room. I was going to talk about how we have to bring people together. It's like one of those theaters in like a dark room where everybody sits and all interspersed and nobody wants to come to the front row. So if we can figure out a way to bring people to the front row, we might solve some of the problems of community and global health. I've given a number of talks. because I've done a lot of stuff on communications, especially with people that want to deal with the media or deal with the public. And part of what I'm going to talk about is not specifically about health issues, so I'm going to talk about the difficulties, especially in the United States, of communicating around global health and getting people involved in it, more involved in it than they are. One of the things I've done is tell people that, there's 5 rules to remember when you communicate with the public or the media. Keep in mind these 5 rules. I'm not going to go through those today. But the first one I always say is tell the truth, be honest. And I'm always amazed about half the audience starts writing it down. Like, okay, I got the first rule. Be honest. I think I can do that. And tell me the other 4. The first problem, I think, with global health in communication and in discussion with not only the publics, both internationally and nationally, but also among elites. It's interesting how very much elites, political elites, media elites, people that cover health as an issue, people that are one step removed, wire reporters, anybody that's sort of one direct step removed from it, have a very similar background of information that the general public does. And it's very cursory, but they also have a pretty good sense of things. The first problem with communication on global health is nobody knows what that means. When you ask people about global health, when you first say, what do you think about global health, they first think you're talking about the warming of the planet, climate change. They don't go directly to human health. And so when we have this conversation, we have conversations around this campus and we talk about global health, there's a whole vast group of folks out there that don't have the same body of knowledge that we do or that we might in communicating. And that always is the first and most important thing to remember to keep in mind when you're communicating is what we might know may be nowhere near what somebody else knows. So the first problem, just in the broad category of global health, is people don't really know what that means. The other thing that we're faced with, both in the United States and in many developed countries, many richer countries in the world, is we're now at a time of limited resources and scarce political capital. And at a time of limited resources and scarce political capital, people's desire and of investing in health, global health improvements in developing countries is very low. They basically look at it like we have all these problems at home, we got all these things going on, yeah, I want to do it, it's the right thing to do, but I'm faced with all these situations that I have here, why should I care about what's going on in Ethiopia when I got all this stuff going on in my own country and in my own community? And you combine that with all of this debate and discussion about the healthcare system in the United States. So simultaneously, that everybody's talking about like we need to do all these health things in Africa or India or South America or whatever happens to be. And then we have all these discussions about the problems of the healthcare system in the United States. And it's a little, when you try to have that communications with folks about the importance of investments in global health internationally, and then at the same time have this huge debate about the healthcare system in the United States for one, it becomes a disconnect with people. And of course, the first thing they're going to focus on is what's going on in their own country. And so I think with that situation, which is a difficult situation because what we have today is a lot of politicians and a lot of political leaders who have gone out ahead of the public on this and the billions of dollars and all the investments that are made when the public has not caught up with them. And that basically leaves many politicians and leaders out on a limb that can easily, in a bad political environment, be sawed off on them. And so a lot of these leaders have invested and put all this money into much of what's obviously been very successful improvements, but politically, the rest of the country and the rest of the citizens in these countries are behind where those leaders are. And in that environment, you basically have, which I'd like to describe as like this dry timber environment. And most of the time when you start messaging and all that, you try to figure out where the timber is and you can light a fire and watch that timber move. It's not so much creating this mass movement, it's finding out where the dry timber is and lighting a fire. Much of the dry timber around the world right now, especially in wealthier countries, could be raised opposed to global investments in health, as opposed to for them. And so in that environment, what do we have to do? We have to figure out how to engage the public and how to build, as Joe said, how do we make this more not only globally but community? Why should somebody care as much about what goes on in a village in Africa as they do in Akron, Ohio? And we have to figure out how to bridge that divide and get to a place where we can engage people and get them involved in this, though it may be 3,000, 4,000, 5,000 miles away. Because ultimately, We can get politicians and we can get leaders and we can get a lot of people to make investments, but over time, they are ultimately going to respond to what the politics of the issue is. They may do that in a short term, which in many places around the world has happened, but in the long term, they're going to have to feel like there's a political environment that is positive for them to do that. And the other part of this is there is now a group of folks, 18 to 27, 18 to 28-year-olds in this country, that are ready to get more involved. It's sort of what we call the 9/11 generation. They have the highest levels since the greatest generation. They have highest levels of involvement and volunteering, though not in the same ways that our parents and grandparents did. And so how do we get them involved? How do we get them involved in this at a time where their attention span is totally diverse in what they want to be involved with? So the first thing, I think, in doing that and creating that environment and making people feel connected to communities that are 3,000 miles away and why they may want to be attuned to that, is we have to figure out the better way to talk about global health as an issue. And the first big problem today that we have is that there's problem fatigue. People have heard about the problem. They know all these problems. They know all these bad health situations. They know all that. But what they haven't heard about is what's actually succeeded. So they know all this money's getting spent. They know all these terrible things. They've seen all the commercials. They've seen all that. And so what's happened, and many people that are involved in global health and health internationally, is they have stayed too long on the problem when people already understand the problem. So we have to get off of that. The second thing is we got to tell stories better. People respond not to macro statistics about we've changed this arc on this statistical model and we've done this, but to some particular story with somebody's name on it. Somebody in a village who's been helped, who can now live a life that's empowered. And in the public's mind, it's holistic. We have a tendency to talk in all these vertical paths about diseases. The public's mind, and most media elites' mind, is they see it more holistically. They think that if you tell me you saved somebody from malaria, the first question in the mouth, well, did they die the next week from polio? Did they die the next week from AIDS? Or did they starve to death? And so it's a much more holistic approach to our communications related to global health and not a vertical disease approach, which is much of how we've communicated this. The third thing is we got to figure out different ways and means to communicate these success stories and the ways in which we're going to talk about this to build public support for this. So it's not just we're going to get a great documentary that's going to be done on some channel somewhere. That we got to figure out how we can tell stories that create a viral nature to this. Why would somebody forward something on YouTube to get to somebody to look at it, to look at a story about something that's happened in Indonesia or something that some great success happened? And finally, one thing I want to emphasize is we too quickly go to statistical models and the issues. So we think we can grab a hold of somebody and say, let me give you the statistics. When most people in their mind, most people in how they make a decision and how they get involved starts in their gut and in their heart, and ultimately they need a confirming rationale in their head. And too much that I've seen that we have involved in global health and the discussions about global health, about building communities around the country, we try to start in people's heads. We try to say, we're going to get in their head, and if we get in their head and we convince them of all these 7 points that we have, that we're going to get their heart and their gut. That's not how people behave in the world. They get something, they believe something that's of value in their gut, they believe in accountability, they believe that there's some compassion, they believe in their tolerance, whatever that value is, and then they look for something to confirm in their head. And the final thing I wanted to say, which is related to 18 to 29-year-olds or 18 to 28-year-olds. I have an oldest son who just got back from Iraq. He had enlisted, which is an interesting thing because here's a kid that was doing very well in college. After his freshman year, decided it wasn't enough. He wanted to do something else. There's a huge part of this generation. Went on his own, got enlisted in the Army, ended up getting trained to speak Arabic, and ended up in outside of Sadr City. And when he came home, he didn't talk about all the sort of track of all the insurgents and all that. The first thing he said that impressed him or impacted him the most was the poverty and the poorness and what he saw among the kids in the villages in that country. It wasn't anything to do with the war. It was the poverty and the lack of health care and all of those sorts of things, which leads me to my final thing is I think we have to come up with something that is this generation's version of the Peace Corps. I think that is much of what they're looking for. It's not that we have to make them do it or like convince them to do it. They want to do it. There's just not an avenue. And most of these 18 to 29-year-olds think the Peace Corps was something that their father or their grandfather did. And so they want to do something. They want to get involved internationally. They want to be over there. They want to do this. And the replication effect of them doing this is much bigger because it not only affects them, it affects their parents, it affects their teachers back here, it affects their people in their churches. And so to me, getting more community involvement has a lot to do with messaging and all that, but it also has to do with some programmatic thing that is our new version, whether it's directly related to a health, which I actually think would be a great thing that was just a pure something related to health that was related to the Peace Corps, that was the new version. And for me, we're going to fundamentally change a generation if we can figure out a way to tap into that, because those folks are ready and willing and able to do that. So I know the time is up. I'm going to close on that. We're going to go to our next one, and I think there's going to be a little time for questions. Thank y'all.
So we're off and running on our big ideas. I think that would be great to have a modern version of the Peace Corps, and I think you're right. There is a hunger, and it would bring people along. Our next speaker is Bjorn Lomborg. He's an adjunct professor at the Copenhagen Business School. He's the organizer of the Copenhagen Consensus Center, which brings together some of the world's top economists, including 5 Nobel laureates, to set priorities for the world. And this I like. In 2008, he was named one of the 50 people who could save the planet by the Guardian in the United Kingdom. And I think that is, if for no other reason, it's a good reason to pay attention to him, because somebody's got to save the planet. Thank you.
Thank you. And I think it's a very interesting idea if we're going to talk about not how to save the world, but what is a good idea. Yeah, because at the end of the day, I think that's very much also what Matt brought up. We need to get something that can actually energize all of us. So I'd like to talk about something that both includes what Joe talked about. I don't know if I get the right timer up here. If somebody reset it, or if I just get some of yours. Thank you. This should not just be about global, but it should also be about how do we actually implement global ideas in a local setting. But it should also be about recognizing what I think was two of your good points. The idea that we have scarce resources. We can't do everything. So let's start talking about what can we do, and also realize that people have problem fatigue. We've heard so much about these problems. How do we turn that around and actually make it into something that we can use? I'd like to talk to you about something that I do, namely called the Copenhagen Consensus, and then try to move you to exactly how could we utilize this to bring forth an idea of how to think about healthcare, and especially in the third world. We run something called the Copenhagen Consensus, where we look at, listen, there are lots and lots of problems in the world. There's 15 million people who die from easily curable infectious diseases. There are 2 civil wars each year that cost about $60 billion on average, mostly actually in health costs. We have about 1.5 million people who die from indoor air pollution. We have a lot of problems. There's 1 billion people without clean drinking water. You know all these stories. The point is, though, we can't, or we don't, fix all of these problems. So shouldn't we start talking about what should we do first? Energize people in thinking about, listen, why don't we do the things where we can actually do a lot of good before the places where we can only do a little good? That's essentially what we try to do, because we do prioritize. Not only don't we have enough money, but we don't have enough time. If something is the top story on CNN, something else is not. And the worry that I have is very often that it ends up being the things that we worry about are the ones that have the best PR departments, the ones that have the cutest animals, or the most image-rich topic areas. And so the boring problems very often slip off our notice board. But it shouldn't necessarily be that way. What we try to do is to then try to engage people in thinking about where can you actually do the most good for the investments that you bring along. This is what we do together with some of the world's top economists. We look at a vast range of different areas. We've looked from anywhere from air pollution to conflicts to diseases, education, global warming, of course, hunger, water, trade, and terrorism, actually, and women. So we've looked across all these different areas and asked people in all of these areas, where do you believe are the very best things to be done? But not just asking that question, because at the end of the day, there's lots of solutions out there. There are lots of good ideas, but also asking how much is it going to cost and how much good is it going to do? So we do exactly what you ask. We move from problems. Yes, we organize our thinking around problems, but we ask people to come up with solutions. I drove up here yesterday with a woman who was very adamant about saying, it's water, it's clean drinking water that's the solution. And I think every one of us in this room have this idea that it's this solution that's the right one. But we have that knowledge. What we have to also do, and to be honest about doing, is to look at what's the cost and what's the benefit to deal with those. That's what we do. We bring together some of the world's top economists in each of these areas. We had Dean Jameson, who's done the World Health Organization's focus on the cost-benefit analysis of virtually all diseases. And we had a lot of economists in each of these areas explaining us what can be done, what are the smartest things to do, how much do they cost, how much good do they do. Then we bring together, as you also mentioned, Joe, a panel of 8 of the world's top economists, 5 Nobel laureates, that look across all these different areas and say, well, which of these many solutions are the very best ones? Where do you actually get the very most bang for the buck? And I think that's the crucial argument, that you have to come up not just with a good idea, but with the best idea. Charles Krauthammer from the Washington Post calls this a thought Olympics, in a sense. Imagine all of the good ideas running, but seeing which ones run the furthest, or which ones get the closest. If I can just engage you very, very briefly, and I know I only have 10 minutes, so there's no way we can do this in a sensible way, but imagine if you had to make decisions. Imagine if you were Bill Gates, if you were at the Gates Foundation, if you were at a public office. Imagine how would you spend money. I'm just going to give you 3 solutions. You could try to fix tuberculosis, you could try to fix education, or you could try to fix malnutrition. Now, there are lots of different solutions. I'm only going to give you one, and I am only going to give you a very, very brief description of this. Obviously, we could have a large conversation about all these, but what I find is that when you ask people to do this, it really changes the way they start thinking. Tuberculosis, Dean Jameson tells us that for about $1 billion a year, we could probably save about 1 million people from dying from tuberculosis at an average age of about 30 years. It turns into the benefit cost ratio, if you set it at $1,000 per life year saved, disability adjusted life year saved, it's about a factor of 30 to 1. So for every dollar you spend, you do $30 worth of good. Now, a lot of the economists didn't actually believe this number. They thought it was dramatically exaggerated. It was probably not going to scale well, and so they actually found that it was probably more likely to be around $10, but still a great investment. The question, though, is it the best one? We also know that education is a hugely important issue. A lot of people say it's the very most important one. But what can we do? Well, you shouldn't build more schools. Indonesia tried that. Turns out that they actually doubled the number of schools, but they only increased attendance about 1%. It just doesn't work that way. What you should do is you should lower the cost of education. You should lower the cost of schooling. The benefit cost ratio was assumed, if you spend about $3.6 billion, to be about 20 to 1. So for every dollar you spend, you end up doing $20 worth of good. The last one was malnutrition. Again, there's very many different ways you could go about doing this. You could give people more calories, but that turns out to be very expensive. You could also focus on the dramatic lack of micronutrients. And actually, it was estimated that for just about $380 million, not billion dollars, $1 million, we could make better life for virtually half this planet, simply because we could address the issues of lack of iron, iodine, iodine and vitamin A, and zinc. It'd be incredibly cheap, and it would actually end up doing an amazing amount of good. It was estimated in papers about 17. The Nobel laureates actually believe it was much higher, probably around 30, because there's a lot of knock-on effects. Now, the point here is to say, which one of these 3 would you prioritize first? It's not about saying that we wouldn't want to do all of them, but if you could only do one, which one would be on the top of your list? Imagine having to do that. And also imagine having to say what should not be on the top of the list, what should perhaps be at the bottom of the list. The point, it seems to me, is, and that's where it really strikes me that this has an effect, it gets everybody to start thinking about, we have most of this research, but let's try to make it visible to everyone. It gets the public's attention. It gets everybody debating. We have had lots and lots of people talk about this in many, many different forums. And at the end of the day, it's very, very easy to involve the politicians. So what's my good idea? It is to say, let's try to do this. in some of the developing countries and many of the emerging markets, we're going to have huge investments in health. India, China, many other places are going to spend hundreds of billions of dollars every year on better health. Why don't we start having a conversation about where could you do the most good first? We're going to try to do, and we're working with pharma and the industry to try to do this for India. The amazing thing, I think, is this would be a great way to get all the people in all the different sectors, all the people working within their little silos, to start coming up with the argument, not just of saying, yeah, you have a great idea, but you have the best idea. How much will you benefit if we gave you $1 billion? How much bang for the buck would be in your program? It would be a great way to get everybody to talk about this. We'd actually get the public's attention. We'd get everybody to talk about in India, where should we spend our money? We're going to be spending hundreds of billions of dollars. Don't we want to think about how do we do that in the best possible way? It gives us a common language. I think it's great for getting the public to start thinking about where should we prioritize first. You could imagine having the big papers, we're talking to the Hindustan Times and many others, to actually have a vote between their readers. Have people start thinking about where would I want to spend my money first. Now, obviously, you will be influenced by what you also know your own, your personal or your family's history is, but you'd also be influenced by the good data. And then at the end of the day, it's also something that we could get everybody, also the political leaders, to start thinking about doing. We've done this in many other settings. We've gotten the relevant political leaders together, sit them down for a day, go through all the academic research. Obviously, you won't get the full picture, but you'll get a much better picture, and you'll get a much better sense of all the amazing things that you can do, but also which of these amazing things are the very best ones. So hopefully, this would be a way that we could actually get everyone to start thinking smarter about dealing with the huge problems that we have with healthcare in the future, but thinking rationally and saying, this is something I want to participate in. This is something I want to know. Where can I do the most good? And actually end up having a more rational conversation. I think that could be a really great idea. Thank you.
Thanks, Bjorn. Next up, we have Peter Agre. He's the university professor and director of the Malaria Research Institute at the Bloomberg School of Public Health at Johns Hopkins University. Dr. Agre has served as Vice Chancellor for Science and Technology and James B. Duke Professor of Cell Biology at Duke University School of Medicine before he came to Hopkins. He's a member of the National Academy of Sciences and the Institute of Medicine. In February in 2009, Dr. Agre became the president of the American Association for the Advancement of Science. And oh yes, he won a Nobel Prize in Chemistry in 2003. Thank you, Dr. Agre.
Thank you, Joe. Last Sunday, a voice was silenced when we lost Frank McCourt. McCourt, I think more than anybody I've met, has put a human face on serious issues such as poverty and the death of children. And so when invited to participate in this forum, I thought maybe I would just use my own experiences to try to illustrate why I, as a 60-year-old medical doctor, I'm so excited to now play some small role in global health. And I have nothing to say that's as compelling as McCourt's stories, so don't get your hopes up. So I thought I'd just sort of tell you about my background a little bit. So, born to a Norwegian Lutheran family in Minnesota, early in our lives, we got the lessons at night. My mother would read books to us. She was not a college-educated person, but she would read to us all the great books. But also read to us from the children's Bible. So early on, we became imbued with the idea of helping our fellow men. Am I my brother's keeper? And literally and figuratively, I think we all grew up understanding the answer was yes. Well, moreover, in our community was a very important group of individuals who were the medical missionaries of the Norwegian Lutheran Church. And we knew these people. They were some very prominent. Our congressman, Walter Judd, was a medical doctor, missionary in China. Our governor's sister, Alice Eastwald, was a nurse who, with her husband, Conrad, a surgeon, went to Cameroon for 35 years to start a medical clinic. And so as I grew up, I thought this sounded like a really wonderful career. But like a lot of young people, you have a lot of uncertainties. But I decided as a college student I'd like to go into medicine because I thought this would be a very good way of having a great life and doing good things. And it was, I think, when I applied to the University of Minnesota, it occurred to me that I might not have all of the credentials needed to be a successful practicing doctor. Anybody who's attended that university knows that you, at least in the past, had to take, as part of the application, the Minnesota Multiphasic Personality Inventory, a very complex psychological inventory where every personal question is asked in multiple ways. So at the interview, I remember facing the dean when he asked me if I had any questions. I said, "What did you learn about me from this MMPI exam?" He looked in my folder and stared right at me and says, "These results indicate that you lie more than average." And I was aghast. Then he looked down and says, "But you lie less than the average medical student." Anyway, I was interested in global health, world health, and was fortunate enough to be accepted at Johns Hopkins in Baltimore, Maryland, where a very wonderful program in international health was located. And as a medical student, I worked in a laboratory on the problems of cholera. Now, cholera is a horrible diarrheal disease, killing tens, perhaps hundreds of thousands of small children every year. It was sweeping through Asia at the time. And our laboratory took a very basic approach, and I found it fascinating. And the individuals I worked with went on to make some very important developments, the oral rehydration therapy for cholera. This is a problem of moving fluid from our peripheral blood into diarrheal fluids so fast that the people could not keep up and they would die. And a naive person that I was, I recall distinctly going to a mixer at Goucher College, meeting a very attractive young lady who wanted to chat with me. I understand you're a medical student. What are you planning to do? And I got the sense she was hoping I would say radiology or neurosurgery, but I told her the truth. I said, "I'm interested in diarrhea." That was the end of that relationship. Fortunately, I met my wife, Mary, who worked in a laboratory at Hopkins, grew up on a farm, and was not the least bit squeamish about this sort of research. I just didn't take the work home at night. So following clinical training, I decided to try to move into the basic research problems related to world health and studied red blood cells. Of course, red blood cells have a series of diseases, sickle cell anemia, the biology of the Rh antigen, and of course malaria. But our work got more and more basic in its orientation. We discovered a new protein, which was very puzzlesome. Very abundant. It had relatives in other tissues, had relatives in plants even. What was this new protein? We really were stuck. And it was one of our family vacations. As a basic scientist, you'll know that every year your vacation is in a tent. That's the vacation you can afford. We took our children every year camping to the national parks, Glacier National Park, Yosemite. And after a series of these, we said, "Okay, kids, next year you get to pick the national park that we're going to go to." And they all said, "Disney World," which is not a national park. But we compromised. We went to the Everglades. And while passing through Chapel Hill, back to Baltimore, I stopped to visit a friend, John Parker, very distinguished physician, scientist, very knowledgeable about membrane physiology. And I told him about this new protein. He said, "Red cells, renal tubules, plants. Have you considered this might be the long-sought water channel, the basis by which water will enter and leave some tissues very rapidly and cause diseases such as cholera?" And of course I hadn't, but we returned to the lab, we tested this out, and yes, it was a water channel. And got a lot of interest from the scientific community. Of course, this now, for the first time, explained how we could secrete spinal fluid, aqueous humor, tears, sweat, saliva. And if you don't think it's important, urine concentration. Next time you're on an airliner with a full bladder and that seatbelt light goes on, think of aquaporin 2. It's the molecular basis of the plumbing system that makes us so uncomfortable. So, as Joe said, yes, the phone rang in October 2003. It was the Nobel Committee informing me that I would share the Nobel Prize in chemistry. Now, I'm on the line a little dazed early in the morning thinking, chemistry, is this where I tell them that I got a D in high school chemistry? I decided just to hold my peace, thank them, and when I ran to the shower, my wife Mary called my mother back in Minnesota to tell her the news. And Mother never went to college, very thoughtful lady. She listened, she said, "Mary, tell Peter that's very nice, but tell him not to let it go to his head," meaning it is still important to do something useful. And in fact, the opportunity did emerge because about this time, our laboratory had started working on malaria, and we made some small advances in malaria. and I got the invitation to return to Johns Hopkins to direct the Malaria Research Institute at the Johns Hopkins School of Public Health. Now, it's a very wonderful opportunity because this Malaria Research Institute is not involved in the important aid agency activities. They're not involved in distributing bed nets or applying insecticides to sleeping quarters. They're involved in the basic science behind the new developments, the new medicines, the development of vaccines, for example. And it was, in fact, an institute that was created by the very generous gift of an anonymous donor. Imagine giving tens of millions of dollars anonymously. And so this was a great opportunity. I accepted and worked there for the last year and a half and expect to do so for the rest of my life. Now, it's interesting, and I'd like to just share the importance of philanthropy because I think there are several people here that attend the Aspen Institute who are themselves benefactors, and to let them know how important this work is. And it was a conversation that Dean Mike Clagg and I had with our anonymous donor a year ago when I shared that, in fact, people are guessing who the anonymous donor is. And our donor is actually Mayor Michael Bloomberg of New York. And I said, they're guessing who the donor is. They're guessing it's Bill Gates. And Bloomberg smiled and he said, well, I guess it doesn't have to be anonymous anymore. So what are we doing with this funding? And of course, this is the funding that funds activities that we can't get grant money for. We also do get grant money from the National Institutes of Health, Dr. Fauci's institute, to do very basic studies. And I'll just mention them so briefly that as a sort of an overview. They're basic studies in the biology of the parasite. This parasite kills up to 1 million children every year. So of the 9 million children who die before the age of 5 every year, a large fraction of them are dying of malaria. Malaria has been in control in the past, but it's out of control again. We need new understandings. Vector biology, parasite biology, vaccine development, identification of new medicines, I think very important basic work. So, and it also provides an interesting opportunity. We have a field station in Zambia. Now, those of you familiar with geography will recall that the former British colony of Rhodesia is split in half. Northern Rhodesia is Zambia, southern Rhodesia is Zimbabwe. These are two countries that have some of the world's largest health problems. The average lifespan in these countries is under the age of 40. Somewhere between 150 and 200 children out of every 1,000 die before the age of 5. So there's a big challenge. We're looking for new breakthroughs. We hope we will change things. And the big idea, I guess, I'd like to share with you is you can also change the world through science. And my observations are you don't have to be a genius to do something important in life. And my advice to young people is follow your dream. And my advice to those who are not so young is that it is never too late to follow your dream. Thank you.
Very nice. Well, our next speaker is Ben Anderson. He's a surgeon and associate professor of surgery at the University of Washington School of Medicine, and he's also the director of the Breast Health Center there. Dr. Anderson has served as president of the American Society of Breast Disease and from 2005 to 2007, and also served as private sector advisor on cancer control to U.S. Health and Human Services Secretary Michael Levitt on the U.S. delegation to the World Health Organization Assembly in 2005. Oh, and I forgot to note this earlier. He and I share an alma mater. He went to Pomona College, which is a great school. Dr. Anderson.
Thank you, Joe. I did not realize this was a Sage Hen reunion. So the idea that I would like to suggest is the following, that evidence-based resource stratification should be used as a guide for decision-making in healthcare. Now, if I haven't put you to sleep with that, I'm hoping in the next 10 minutes that you'll understand what I mean by that and why this is so important. It's first important to recognize that policymaking and decision-making are related but different areas. Policymaking is what our government leaders need to do to help us change direction, and this is true in our country, in the U.S., and other countries as well. But within this, decisions need to be made about how things should be done. And what I would suggest is that it is the role of the medical community to provide tools for decision making, to provide a framework that can be used so that good policies can be developed. Right now, Congress is trying to grapple with this idea of how do we cut healthcare costs? Well, how's Congress going to figure that out? Actually, it's really the medical community that needs to provide the tools that will make this relevant. The context that I'm going to talk about is cancer. And I think that there are some important misconceptions about cancer in the globe, particularly in what are called developing countries. I have to tell you, although WHO uses this term, I'm not crazy about it because it would imply that those of us in high-resource countries are developed. And actually, I think the recent economic travesty that we're suffering is evidence that we haven't figured the whole thing out yet. But so I would prefer to use the term low and middle income countries because these are the countries where these issues are so problematic that we want to make improvements. Cancer is often thought to be not really that big of a problem in these low and middle income countries, when in fact there are 4.4 million deaths per year due to cancer, which is more than respiratory infections at 3.5 million, respiratory diseases at 3.0 million, and HIV/AIDS, which is 2.7 million. That was 2005 statistics. So I would argue that in fact cancer is relevant to low and middle income countries. I would also argue that it's really not useful to have this discussion about, well, my disease is better than your disease. Because, in fact, what we need are infrastructures that support all of this. That it's the same system that's going to care for cancer and diabetes and infectious disease, and we need to create structures that support all of them at the same time. And so how can we do this in an intelligent and thoughtful way? Breast cancer is the most common cancer among women around the globe. It's the most likely reason that a woman will die of cancer. This is a plug for our session at 2:30 on breast cancer. We'll hear more about this in detail. But actually, the majority of breast cancer deaths, 55%, occur in low and middle income countries, the majority of deaths. So the idea that breast cancer is just a problem of wealthy countries, that's not true either. But I'm not talking to you about breast cancer just because it's the disease that I'm involved in and care for. Actually, I think that the systems that we can work out here are relevant. And what we want to do is look at models that are useful and appropriate. I direct a program at the Fred Hutchinson Cancer Research Center. This was co-founded by the Hutch and Susan G. Komen for the Cure. And what we do is we strive to develop, implement, and study evidence-based, economically feasible, and culturally appropriate guidelines for breast health and cancer control in low and middle income countries with the goal of improving breast cancer outcome. When we do cancer care is often driven by algorithms because we've done these studies that show what works and what doesn't. And so you need to follow organized patterns in order to do this. Indeed, we have assembled important, valuable guidelines, such as the National Comprehensive Cancer Network, NCCN guidelines, or St. Gallen in Europe. The problem with these guidelines is that what they do is they assume infinite resources and then ask the question, well, from a scientific standpoint, how do we put these together in the best way to minimize the chances of cancer occurring? And because they assume infinite resources, that it means it doesn't apply to at least 80% of the world. They provide no guidance on how to utilize resources in the most effective fashion to actually improve real-world outcome. So we started in 2002 in the Breast Health Global Initiative to develop these guidelines fairly naively, but we modeled ourselves after the NCCN, pulled together global leaders in breast cancer, both from the low and middle income countries and the higher resource countries. And using an evidence-based model for analysis of the information that was available, we, through a series of 3 global summits, created these guidelines that serve as a framework for how to address breast care. And what I'd like to do is show you that this is really a model that can be used in other areas. The Institute of Medicine was with us in our second global summit and has actually endorsed this process as something that should be useful for other treatable cancers and other chronic diseases. So the idea is then that we want to take first a systematic approach to understand, well, what works in cancer. And in cancer, you have to go through a sequence. Ideally, we would prevent cancers, so elimination of tobacco, that's going to prevent a lot of cancers. Breast cancer doesn't have a tobacco. It has a bunch of low-level risk factors that are largely related to reproductive health. And so while we can do the right things and do well, we still will have breast cancer as a very prominent problem. And therefore, what we have to do is we have to walk through a sequence of early detection, diagnosis, prove it's cancer, and then treat it appropriately based upon the information that tells us what will work. It's interesting to see that when you go to the low-income countries, such as those in Africa, diagnosis and treatment can really be in disarray. So a woman with a locally advanced breast cancer may go and she'd see a surgeon who would then do a mastectomy. And nothing else would happen because their system wasn't functional. The problem with that, if you take a locally advanced breast cancer and remove the breast, you will not impact significantly on her long-term survival. In fact, because what she needs is drug therapy and radiation to address the microscopic disease elsewhere in the body that ultimately would be the cause of her death. Indeed, when you go to some places, they say, why would I go to the hospital for early detection? All they're going to do is cut off my breast and I'll be dead in 2 years. And you know, because the system was dysfunctional, the system was actually making that true. So you need to look at this in an organized fashion, and in the low-income countries, making treatment organized using fundamental tools is appropriate. In the middle-income countries, patient treatment may well be in place, but patients are still coming in with advanced stage disease. So early detection really plays a much more important role once diagnosis and treatment are in place. What the panels did in this guideline development is created a framework in which resources are stratified in 4 levels: basic, limited, enhanced, maximal. Basic level resources are those that without these, you can't start. You need to be able to do surgery for breast cancer. There's some drug therapies, such as tamoxifen, which make a huge difference in outcome for estrogen receptor positive cancers. Limited level resources were defined as those that would improve survival significantly. Enhanced level resources are those that would improve options, such as breast conserving therapy, lumpectomy and radiation instead of mastectomy, which doesn't make people live longer, but certainly makes the therapy relevant. And most important, this concept of maximal, there's some resources that may be really wonderful, but when you ask, gosh, this expensive tool, how many lives am I saving with this? I use MRI daily in my practice, but if you ask how many lives does breast MRI save, the answer may be 0. And so we have to think of this in this orderly fashion. We've now published these guidelines and are moving into an implementation phase where we're developing learning laboratories in different regions of the world, working with people in country. It is critical, as the prior speaker said, it actually has to be the people in country driving this forward. We're here, in some ways, to learn from them. How do you manage this problem in your setting? Now, as we move forward in this area of this, what does this have to do with our work in national policy? I would suggest that actually it's the Americans that are the most uncomfortable with the idea of resource stratification. When I teach medical students and I ask them, what's the problem with the following therapy? The last thing on the list is cost. We don't teach in medicine how much things cost, and we haven't developed a methodology for considering cost as we do this. People in other countries are actually quite used to this because this is what they have been living with. And so we want to develop this integrated approach, considering resources in a stratification fashion. And what I would suggest that we do is that we use an organized model for resource stratification and look for synergy between different disease processes so that we can create a basic level healthcare system that should function to treat many diseases, not just my favorite. Yesterday, the question came up, is healthcare a right or a responsibility? And that's a very tough question. I would suggest to you that basic healthcare is a right. And the question becomes, how do we define what basic is so that we can actually make a difference? I think this is where our government needs to be going today, and I'm hopeful that this framework is something that can be useful to others. Thank you.
Thanks very much. Our next speaker is Dr. Robert Sebbag. He's the Vice President for Access to Medicines at Sanofi Aventis. In his role, Dr. Sebbag participates in the company's Access to Medicine strategy development for the Southern Hemisphere. Prior to joining Sanofi Aventis, Dr. Sebbag worked in Brussels for the European Pharmaceutical Industry Association on creating a communications platform for the pharmaceutical companies operating in Europe. Dr. Sebbag is a doctor in medicine with psychiatry training and expertise in tropical parasitic diseases.
Thank you very much. What a challenge, really. When I receive, say, you have to speak about a big idea, I see who I am to give a big idea. When you know all the people working all around the world, it's many, many institutions, all the government, I say, why? What can I say? Oh, for sure, as a medical doctor, as a specialist in infectious disease, you forget to say in my bio that I was head of the Red Cross and I create Médecins Sans Frontières and so many other NGOs. And I have seen a lot of things. I was medical doctor in Vietnam just after the war, and in Bolivia I have seen a lot of things, and I understand really what you say, Peter. And I say perhaps I can say as Martin Luther King, I have a dream: no malaria tomorrow, no TB tomorrow. No sleeping sickness, no more leishmaniasis, etc. It's not only a dream, because now we have the means, technical means. We know how to treat malaria. We know how to treat TB, even multi-drug resistant TB. We have the means. Why it doesn't work? What about mental health in developing countries? Nobody speaks about mental health. We have the same amount of people in North and the South. Nobody cares about mental health in developing countries. What about epilepsy? What about chronic disease? About diabetes only? And I was thinking about that. What can I say? What is my big idea? Economy plays a role. Because now, very often, when we speak about global health in the South, in developing countries, is charity, is philanthropy. Philanthropy is very important. It's very important. Donation of drug is very important, but it's not a sustainable solution. Donation of drug, okay, tsunami. You have a tsunami, you have to help in emergency people. 250,000 deaths is in 2 days. But if you take malaria, AIDS, and TB, very often I say one tsunami every month for each disease. It's one tsunami every month for each disease. And we have the means. What is wrong? And try to be able to, don't be naive. Try to find really a solution. And I agree also when you say we need some holistic solution. Why malaria? Why TB alone? Why polio? It's very important, but I'm sorry, I suffer from diabetes or from epilepsy. For me, it's much more important than malaria or TB. How to make a choice. It's why I had a delusion, to say, what can we imagine? And I see some statistics, I agree with you. Now, in sub-Saharan countries, the average of expenses for health is less than $2 per year and per person. Less than $2 per year and per person. This is a reality. And I say, now, what about insurance? You know what is microcredit? Why not macro insurance, micro insurance, to commit the people themselves? Because it's a tradition in Africa, They give money to what they call a tontine in the French-speaking Africa. They have loan of money. Say, if we can apply for health, and I make the assumption, 10 times 2,000 US is 20 US per person and per year for health. We give. For 1 billion people is 20 billion US per year. Nobody is sick in developing country. And we made an experience in Benin with the same amount of money, but in the same time you need to organize health center. Agreed. Else this center you will receive people with this microinsurance. They pay 20 US per year and per person. You need also, disease by disease, to say, okay, for the disease we have to treat with this one, and the cost. I think it's not a dream. And it's sustainable one. Today we have the Global Fund with billion of US to fight TB, malaria, and AIDS. Okay, tomorrow it's a big crisis. You are sure that your government in US, my government in France or in UK, they will maintain the donation? We don't know. It's a risk. Where is the sustainability of donation or philanthropy? It's why we have to find something, an incentive. You know, in Africa, this is my own experience, the people, even if they have not a lot of money, they are ready to put money if they receive the feedback in terms of health. If it's a good product, if it's a good care for them, they are ready to pay. But if it's to pay for counterfeiting drug, they are not going to pay. It's why we try, as a pilot, what is 20 billion US for 1 billion people? How much we give in France for the crisis? I don't know, 50 billion. How much in the United States? When we need the money, we find the money. We find the money for swine, flu. We find the money, you can believe me. Because north and south will be touched, but north, you have a sort of what I call solidarity of fear. We are in the same boat, everybody. It was the case for AIDS, but after we had seen that the accessibility of drug was not the same in the north and the south. It's why, sorry, with few humility, I try to say, okay, one solution, I don't want to say this disease and not this disease, perhaps is microinsurance. And I make the exercise of 20 US per person and per year, 20 billion, how we can inject. The problem is not to give the money to the people, to inject to the economy 20 billion just to have a sort of insurance for developing country. For US, you will find a solution. I'm not anxious about that. This was my idea, not big idea, but really my idea. Thank you very much.
These are all very provocative ideas, and as we've come to the last talk, and unless Mary Robinson decides to soliloquize for way past this timer, we should have some time for questions after the session after the speakers have presented. So I just wanted to let people know that if they have questions, they should stay around, and we'll try to answer them. But now we are to Mary Robinson. She's the president of Realizing Rights, the Ethical Globalization Initiative, which is in a partnership with the Aspen Institute, Columbia University, and the International Council for Human Rights Policy. Mrs. Robinson served as the United Nations High Commissioner for Human Rights from 1997 to 2002, and she was the president of Ireland from 1990 to 1997, and she's been a tireless worker for human rights through her professional career.
Of course, a woman always likes to get the last word, so I didn't mind being last on this panel. And I think that the idea that I'm going to advance actually sits quite well with the ideas that have been put forward and has a holistic dimension to it, which I think is important at this stage. It links with the really big idea, which was an idea 60 years ago last year, the Universal Declaration of Human Rights, including, of course, health as part of that, the right to the highest attainable standard of health. I watched with bated breath, as some of you may have, that debate, presidential debate between the two final candidates when the question was asked about is health a responsibility, a privilege, or a right? And thankfully, the current president of this country answered correctly. It is a right. And it has to be recognized as such, and there's now, I'm happy to say, a great deal of literature on it. And in our work in Realizing Rights, we work from that perspective. And I just want to focus on one area of our work because I believe it is itself a big idea whose time has come. So I want to put it to you. And again, I'll have to do it in a very short time. The big idea is, like human rights as a whole, the interconnectedness of our world and the interconnectedness of national human rights policy and reform and the impacts it can have internationally. And this is particularly relevant, obviously, in this country now. So the big idea will be stemming from the perspective of the right to health for all, the right to basic health care for all, linking US health reform with US development assistance to address the global health workforce crisis. You cannot strengthen health systems in the poorest countries unless you have doctors and nurses and community health workers and paramedical and other cadres of health workers that I'll just touch on briefly. And that's a factor that we have known about, but I wonder whether we fully understand the seriousness of the issue. As I think you probably know in this room, the World Health Organization estimates that the world is currently short of about 4.5 million health workers. And this isn't an overall global shortage. It's much worse in some areas. There's a lack of equity, lack of fairness about it. So if you look at the reality in Africa, for the reasons we've been hearing, Africa, while suffering from 24% of the global burden of disease, has only 3% of the global health workforce. In Malawi, a population of 50,000 is served on average by a single doctor or may not have a single doctor, whereas a similarly sized population here in the United States would have at least 128 doctors. I will be helping to launch a small maternity hospital in Malawi in October, and there is one doctor. And it just really brings home the reality. There's a lot about the worsening situation in the Democratic Republic of Congo in the news today. I was in the DRC in both Kinshasa and in Goma in March with my colleagues, and we were aware of the terrible problems of sexual violence. And I went into one hospital that again may be known to some of you, Heal Africa, doing incredible work for women who have been terribly raped and sexually assaulted and violated in every sense, and some of the stories were incredible. There were 2 women to a bed in this hospital, and there were far too few, again, qualified health workers to be able to address the problem. And there were women waiting for fistula to have their problems addressed, and they were waiting quite a long time because there were not beds, because, etc., a lack of health workers and a lack of resources. What is part of the problem? Part of the problem is the migration of health workers from low-income countries to this part of the world and the modern Ireland and Europe and other richer countries. They come substantially, of course, from the traditional countries, India, the Philippines, but we also know that they come from very poor countries with very poor health systems. Africa and Caribbean countries are disproportionately affected by the emigration of their health workers to OECD countries. As an example, and this is an interesting statistic in itself, over 50% of the doctors from Antigua and Barbuda, Grenada, Guyana, Mozambique, Angola, Fiji, Sierra Leone, Tanzania, Trinidad and Tobago, Liberia, St. Vincent and the Grenadines, and Haiti practice as expatriates. Over 50% of the doctors from those countries practice as expatriates in OECD countries. The United States health system is itself deeply reliant on expatriate health workers. Almost a quarter of US physicians and a sixth of nurses in the United States are foreign trained, most from low and lower middle income countries, whose training is usually subsidized by the poor governments to enable them to become doctors and nurses in those countries. And I have been following closely the debate on health reform in this country, and I really believe it's extremely important now to start making practical connections and doing something about it. I have the honour to co-chair a high-level health worker migration global policy advisory council with Dr. Francis Omazwa of Uganda. And there are a number of health ministers from developing countries and developed ministers and academics and representatives of medical associations, and indeed Tom Daschle is a member of that council who's speaking in another forum, and I hope he also mentions this issue. So we're working at the moment with US policymakers on the issue of how US domestic health reform has the potential to generate significant positive health outcomes globally, and that this health reform that's taking place here in the United States is actually a global issue because its implications are huge. There is a very real likelihood that the way in which the reform is carried through will mean there will be more need for health workers. And as we know, that is an issue that has to be addressed. The High-Level Policy Council prepared a memorandum for President Obama in the context of his recent visit to Ghana. And we were very pleased indeed to see that in the speech he made in Ghana, he clearly had read the memorandum, or somebody had given him similar advice. But look at the situation in Ghana, the country he visited. While facing the burden of both chronic and infectious diseases and a severe shortage of health workers, Ghana has 30% of its potential physician workforce working here in the United States and serving the health care needs here. Now, let me emphasize immediately, in case you are asking yourselves this question, of course, as a human rights person and with my colleagues in Realizing Rights, we support the right of health workers to try and further their careers, to go abroad if that's, and there are very big pull factors. But we must remember, under international law, a person has the right to leave their own country, but they have no right as such to enter any other country unless that other country provides an opportunity. And in this country, it's actually fast visas to enter the country. So the issue poignantly illustrates the global connectedness and dependence on each other of national health reform and the migration of health workers. So what the big idea that I really would like us to maybe discuss a little when we have question time is that the United States is a major global employer. It's estimated that the United States over the next 20 years will need about 200,000 doctors and about 800,000 nurses to have the kind of level of health reform and services that is being discussed. So it has the opportunity to play a leading role in more ethically managing the negative consequences resulting from health worker migration. Norway is doing this. Norway is leading in Europe. It has decided that it will try to be more self-sufficient, but it has understood from the evidence, and I agree with the point about we should be evidence-based in our approach, that Norway will not be able to meet its own health needs from Norwegian sources alone. And they draw mainly from Central Europe, from Poland and from Czech Republic, Latvia, etc. And they have undertaken to fund the cost of all health workers who will work in the Norwegian system. Not funding individuals, but with a memorandum of understanding with the countries. We took 6 doctors from you last year. That's what it cost. Think if the United States did that for African countries now as part of development assistance. Think of the difference it would make if the United States would pay for the education. And I would say between the United States and poor African countries, it shouldn't be paying for only one. It should be paying for 2. Paying for the fact that the poor country has educated the doctor or nurse that has come to the United States and given the United States a development gain, but also the poor country has lost a doctor or nurse. So it's a funding that would really substantially increase the education and training, and not just of fully qualified doctors and nurses, because there are also clinicians in some African countries that specialize in emergency obstetric care and are working hard with good clinical results on maternal mortality, etc. So I see that I'm almost out of time, and I'm trying to be very rigorous in keeping to it. But what did President Obama say about this in Ghana? His speech seemed to me to be evidence of the United States' readiness to take an ethical leadership role in this area. He said, well, what he did was he acknowledged for the first time the link between the incentives provided by the United States and other richer countries that, if you like, woo health workers, that are part of the stimulus for health workers. There are also factors in their own countries, low pay, lack of training and resources, even discrimination and violence and other issues. But the pull factors are very real. And so he acknowledged that the incentives provided by the United States and other donor countries and the migration of health workers has a negative impact on primary care in those poor source countries. And he stated, and I quote, "Yet because of incentives often provided by donor nations, many African doctors and nurses understandably go overseas. This creates a gap in primary care and basic prevention." So the problem is acknowledged. The question now is, what's the solution going to be? The European Union has also acknowledged in particular more recently. And there is, of course, the World Health Organization's proposal, which hopefully may be adopted next May, of a code of practice for recruiting health workers abroad. But it needs much more than that, as we can see. So when I think about what is the vision of the Policy Council that I co-chair, it's of a world that is abundant in the opportunities to work and train abroad, rich in the exchange of ideas and expertise in the pursuit of further global health, and where every country also has a safe minimum number of trained health workers. And I believe that this is the most important factor in strengthening health systems in the poorest countries, and therefore providing the important implementation of what was guaranteed 60 years ago, in theory anyway, the right to health, the right to the highest attainable standard of health. Thank you very much.
Well, one of the instructions to me as the introducer of this segment, this session, was to synthesize the talks you've just heard, and I'm punting on that one. I don't think I could, but I do have 2 points to make, and then I would like to invite people to ask questions because we do have about 15 minutes left. And I'm told that if you have a question, please come to the microphone on this side, that's stage left, house right of the room, because that's the one that's working. And if you would address your question to one of the speakers, that would help me decide who to call on. But if you don't, I'll figure somebody out. I do have 2 small points that I thought I would share as I was listening to these talks from what Mary Robinson said about the need for health personnel in developing countries, or if you don't like developing, we can use a different word, poorer countries. And what Matthew Dowd said about the yearning for a generation of people in this country to find a mission, a purpose, something that they can do. I do see manpower, human capital, as an important part of solving this problem. And maybe this is a time where people, as Peter Agre said, who would like to follow their dream and do something that they feel is really going to help people around the world and make a difference, maybe providing opportunities for circumstances like that, maybe there's a good time for this. Don't know. It struck me as I was listening. And the other thing I wanted to say, again, as I was thinking about these large ideas that are being expressed here, is the importance, again, of how you're going to present them. Because if you're in a policy forum and you're talking to policy experts, you're permitted to give facts and figures and tables and numbers. But the world runs on anecdote. I think that's why I think if I were judging, many people here found Peter Agre's talk so relevant and powerful because it's a great anecdote of a life lived in an important way. And I think that as someone in the media who's in charge of transmitting these big ideas to the public and perhaps explaining why they're important, anecdote's very powerful, and story is very powerful. And I think the problem that the media gets into sometime, and I don't want to devolve into media bashing, but the problem we get into is choosing the wrong anecdote that doesn't accurately represent the larger situation. So with that, I'm happy to entertain questions from the audience. And I can't see so well because lights are shining in my eyes. But do we have any questions? Yes, go ahead. Yes, and somebody wave the microphone. Oh, it's way over here. I see. Yeah, I know. You sat on the wrong side.
I'd like to thank Mary Robinson for bringing up the issue of workforce. I believe she's really onto something that's very important. But even as we contemplate reform in this country, I think we have to start thinking about more than numbers. We have to start thinking about roles. It's not enough to say we need X number of doctors and X number of nurses. It's what they do. And in that respect, I think there's an opportunity for us to learn from developing countries about frontline healthcare workers and an opportunity to try new models. So appreciate it if you could comment on that. Excuse me.
And let me ask, does Mary have to come up to the lectern, or can she stand where she is and speak? You can stand where I just think rather than have people run up and down, you can just turn around.
Well, I'm actually very grateful for your question and comment, because if I'd had a little bit more time, I'd like to have got into precisely the point that you made. I think we can learn quite a lot from what's happening in practice. It's happening because of health workforce shortage, but it's teaching us a lot, I think. Countries are doing different things. In Ethiopia, the Minister of Health has put great emphasis on primary community-based healthcare, and he has recruited 30,000 girls out of high school with about 2 years training. And I even challenged him, because I know him quite well, and he's got a good sense of humor, as to, was this a bit sexist? And he said, Mary, I don't care, it works. The girls do it, and this is what I need. In 3 African countries that were working in realizing rights in partnership with the Mailman School of Public Health in Colombia, with Trinity Dublin, and with local African partners in Mozambique, Tanzania, and Malawi, there's a project that has gathered very interesting evidence that in those 3 countries, the tradition of having clinicians with special training or mid-level providers who are not fully qualified doctors or obstetricians in the traditional doctor-based obstetrician sense, that these mid-level providers are carrying out the vast majority of the C-sections and the procedures for pregnant women, and there's no statistical difference between their outcomes and the outcomes of the fewer doctors with much fewer procedures. So again, getting back to, I think it was Ben Anderson made the point about being evidence-based. We will display this in October and visit the 3 countries and talk to the presidents there and encourage them to put more value on these mid-level providers, these clinicians with special training, because they're kind of hidden at the moment, and they don't even have a proper career path as such, having done about 6 or 7 years training in the countries, and they have become very expert in obstetric care. It may not be perfect, but it works very well on the ground, and these people don't tend to emigrate because their qualifications wouldn't allow them to carry out the same obstetric. So, in reforming the United States health care, one of your problems, as we know, is very, very high cost. And part of that very high cost is there's far too much influence on the professions determining that certain services have to be delivered by people who are actually overqualified for what they actually do. So, to be able to look at that more honestly, I think would be really very important.
Is there another question? All right, well, I'm going to take the liberty of asking a question. I want to ask Bjorn Lomborg. Having heard these other talks where people have identified particular areas already of their own passion for fixing problems, how would you go to somebody and say that's not the right project because it's not economically powerful enough, we shouldn't be putting our resources there, if it turns out, looking at it on a cost-benefit analysis, it's not the best idea? Or am I not, maybe I didn't understand what you were suggesting, but it does sound like there's a need to, and I'm going to ask you to stand up and answer my question facing away from me, which is a little odd.
Yes.
Or you can come up here and stand
No.
next to me.
I mean, I think it's a good question. No, I think you understood me right. There's obviously an enormous amount of intensity in whatever one does and what one feels is the most important issue. I simply want us to have that conversation of where do we get the most bang for that effort. And I think that was, in a certain way, all of what our speakers were pointing out. They were saying, listen, I have a great project. It's workable. It's incredibly important. It can be done cheaply, and it can do a lot of good. Now, the whole point is to say, if there is something where you can do it even more, you can do it even cheaper, or even help even more people. Isn't that the exact answer to your question? If you can spend $1 billion and do $10 billion worth of good, but there's another project that could spend the same amount of money and do twice as much good, that, I think, is the answer. So at the end of the day, this really is a question of making sure that we have all the good ideas, but that we also have the fiscal responsibility to ask ourselves, well, we don't have infinite resources. Where do we do the most good first?
And maybe I could then turn to Matthew Dowd and say, I mean, as someone who's trying to pitch this, if you will, right? How confident are you that the message, I mean, it sounds like President Obama has taken up some of the message, but how confident are you that this is a message that you can make resonate with people in this country anyway?
Well, I think there's multiple answers to that. I mean, multiple answers to that question that raises other questions. I think fundamentally the problem, and I'll speak in the United States, is there's a disconnect between what we do here and what's going on in the rest of the world. And part of that is by nature of our country, the insular nature of the country. I mean, I was thinking, while everybody was talking, one thing I was thinking, there's been tons of polling done internationally in all the countries and in the United States. And when you look at the regression analysis of all that, the number one factor of the favorability view we have of an African country or any other country in the world and another country's view of us is directly related to whether or not that person has visited the country or whether or not that person has been in contact with somebody from that country. That's the most dominant factor that plays out with whether or not we want to be involved or whether or not a Muslim country has a favorable view or some other country has a favorable view. Is what level of contact they've had with somebody from that country. And so I think it comes down to, which is why sort of I had suggested this idea of how do we get people more, whatever you call it, some new form of the Peace Corps, or however you do that, we have to get a way of resorting the zip codes in the world so that we now can feel like our zip code, that when we look out our window, we don't only see what's in Austin, Texas, or Des Moines, Iowa. We have a way to see what's going on in an African country or South American country in a real way, not just, oh, that's over there and I really feel bad about it and it's the right thing to do. I think many times people in this industry or in this thing have a tendency to try to tell people in a lecturer way that it's the right thing to do, therefore we should do it. Fundamentally, people make decisions that I wouldn't say are in their self-interest, but are in the interest that they believe in their own hearts are the right. They want to decide it's the right thing to do. They don't want to be told it. And the best way, in my view, for that to happen is for some better exchange of personal contact between people in the United States and foreign countries. It has a twofer effect. It not only helps them with assets here, but it helps the United States view way they can be their concerns around the world. So it's a major issue, but I think before you even get to the resolution of the medicinal issue, we have to figure out a way that gets people to cross the bridge that they feel like they have an interest in what goes on in Africa or South America, as opposed to it's just the right thing to do and I should do it.
Well, I've been through my life, I've been hearing about how the world is shrinking through telecommunication, and maybe I don't think it's shrunk yet, but maybe we are getting into a stage where, since you don't know whether the person you're texting or communicating with or something is sitting next to you in the next room or in halfway around the world, maybe there is a different sense that we can connect with people. But anyway, that's where we have to leave it. Thank you all. I hope you'll join me in a round of... yeah, but I've got a little flashing light that says it doesn't matter if there's a question. So I hope you'll join me in thanking our panel, and we are adjourned.